Good morning, my dears. Today's topic is about leprosy. This is a disease which has been in the community since centuries. We have a record about this disease even in the Bible, which means they have stated that people was cured by the vision of the God. So that is actually that records, that marks the presence of disease since centuries. Even before the birth of Christ, the disease was present. So last class we was discussing about the AIDS, the presence of AIDS since 5 decades. It is just 50 years old. But this is a disease from this which has history from ancient times. It's a disease caused by Mycobacterium leprae, which is a bacilli. So this bacilli affects the skin and nerves, and it can involve the organs also. It can involve the immune system also. Mycobacterium leprae is the bacilli which causes the disease. It is a bacilli, which means rod-shaped bacilli. So this bacilli occurs in clusters. They are arranged in a particular pattern that they resemble Chinese letters. So this is also one of the marker or a significant point in finding out the lepra bacilli. And they tend to occur in clusters. That is called blow-by pattern. So Chinese letter pattern, blow-by pattern, acid-fast bacilli. So these are all specific features of Mycobacterium leprae. Now let's move on to the epidemiological triad. Epidemiological triad means the 3 components of a triangle that leads to the disease. So it's not only the agent that can lead to the disease, agent with a susceptible host and a favorable environment will result in the presentation of the disease. So as we all know, the agent is a bacilli, Mycobacterium leprae. And the source of infection, a person from whom they can get the infection, is the source. So it's again an affected case. A case of leprosy forms the source of infection. And the portal of exit is through the direct contact, the skin surface itself, or the nasal secretions. So this is a disease with high infectivity but low pathogenicity. That makes the disease less in the community. So only when the pathogen is virulent, it can affect or it can result in the development of disease in each and every individual to whomsoever it goes and comes out. The attack rate is 4.5% and to 12%. Coming to the host factors, all ages, starting from infant till elderly individuals, it can affect both the sexes. There is no preference for male or female. And of course, there is preference for rural environment. Maybe these are the factors: literacy level, poverty, all these things favors it to take the route towards rural distribution. But of course, it can occur in urban areas. It can exhibit in urban slums where the sanitation is poor. Then followed by when somebody's immunity is less, the disease can take up more like lepromatous pattern. So we have 2 spectrum of leprosy. One is tuberculoid spectrum, and the other is lepromatous spectrum. So more the immunity the person presents with tuberculoid pattern, less the cell-mediated immunity in his body, he goes for lepromatous pattern of leprosy. The environmental factors which favors the flare-up of diseases, overcrowding, as this is it's communicable disease transmitted through nasal secretions, and it is taken in through ingestion. That is the route of transmission. And of course, skin to skin direct contact is also possible. This overcrowding flares up the infection, humidity, and nutritional status of the individual. The more the nutrition, better the immunity. Less the nutritional status, more the infection rate. So that's how epidemiological triad for leprosy. Next, earlier we had separate stream of services to address leprosy. But now, as the disease statistics have come down, burden of disease has been reduced, we have merged the leprosy services with the general health services. The main reasons were patients were detected early because the diagnosis process is very simple and it can be made not only by the specialist person like dermatologist, even a medical officer, even a health worker can be trained. Health worker can be trained to pick up the cases of leprosy. And again, if the treatment is started initially at the early stage itself, the cure is going to be 100%. And the transmission of infection is interrupted when the treatment is started at the early stage itself. And as there is the 100% success rate in curing the disease, the development of deformities. So that is a major headache about this disease. The person goes for deformities of the hands and feet and even deformity of the eye, which makes a person to go for jobless, to go for job loss and get confined to the house itself. And because of stigma that is attached with the disease, thinking that it's a curse of the god, people are thrown out of their houses and they were left on the roads. So this stigma. So because of the good case detection, easy case detection, and good treatment available for this disease, the transmission is being cut and increasing literacy and understanding about the disease, the stigma is being reduced far better. So next we'll go on to how to diagnose or pick up a case of leprosy. So that some presentation of the disease is very simple and can be easily understood so that even a health worker who is trained to how to pick up hypopigmented patches, how to look for sensation, can easily go for diagnosing the disease, which made the disease to get controlled. That is the main reason. The disease presents with a hypopigmented patch. This hypopigmented patch, there are many conditions that can present with hypopigmented patch. One such as even photodermatitis. When somebody reacts to the sun in a hypersensitive way, they can present like this with a annular patch, raised elevated border and flat center. Or it can be because of pityriasis alba lesions, very commonly presenting in the face, that too in the children. Or it can be a tinea corporis, which can occur as annular patches with central clearing. Or it can be vitiligo also. So how to make this, how to diagnose this hypopigmented patch of leprosy? It's basically based on the sensation test. So after picking up the hypopigmented patches, the health worker or the doctor will go for testing the sensation over that area. So the sensation, if it is impaired or lost, we'll have to think about leprosy. So when somebody sees a hypopigmented patch, definitely you should go for sensation test. So just have a wisp of cotton and ask the patient to close the eyes, and you touch and you ask them where you have touched to locate the place where you have touched. If they are able to do, the sensation is preserved. If they are touching at a separate, different point, then there is impairment of sensation or complete loss of sensation. Of course, you can go with the folding a piece of paper and making it into a sharp edge and make a small dimple over that affected area and compare with the normal area. And if the sensation is decreased, again, we have tested for the crude touch and the fine touch over. Sensation is reduced. One more way of testing, checking the sensation is loss of function over that area. The patient will not sweat in that round patch. So if the same person is asked to go for a round or climb the stairs up and down for few minutes and made to sweat, the small circular patch alone will not sweat. That is the area where the function is being, secretory function is being lost. So these are the two preliminary tests over that hypopigmented area to make the diagnosis of leprosy. So as this is simple, very easy, when it takes less time for diagnosis, the cases have been detected very fast and they were started treatment at the early stages. So this is how to go with the diagnosis of leprosy. While addressing to the patient with a hypopigmented patch, we need to be friendly. We'll have to give correct information about the disease. And if at all, if they raise doubts, we'll have to answer them. And definitely we'll have to maintain the confidentiality about the diagnosis. We'll have to keep up the records, and the multi-drug treatment which we are going to give him should be in a flexible manner. And we have to assure that the drug is supplied at the correct time at the free of cost. So how to diagnose leprosy? Let me tell you once again. We'll have to examine the skin. The whole body should be examined, to be excluding the private parts. So the whole body, starting from head to toe, and both front and back should be examined. Many times we miss the diagnosis as it can occur at the back also. So we'll have to examine if there are hypopigmented patches. Next question would be, since when they have this patch? If they say if it's a mole can present in a hypopigmented way also or hyperpigmented way also. So if it's there since birth, it is considered as a mole. If the patient doesn't know about the presence of lesion, whether it was present during birth or since birth or quite a long period, then no doubt go for sensation test over that area. If sensation is lost, it is leprosy patch. If sensation is preserved and hypopigmented patch, it's a mole, white mole, or nevus achromicus, nevus depigmentosus, or nevus anemicus. Next is check for patches. So it can be macule or it can be a patch, raised border with flat center, and go for test sensation. Both fine touch and crude touch should be tested. So fine touch can be done with a wisp of cotton, and crude touch can be done with a sharp edge. So see to it that you don't harm the patient by pricking in a rude way. Count the number of patches, even that matters. So if the number of patches are between 1 to 2, 1 to 5, they fall under a different category. And if they have 5 or more than 5 patches, they fall into different category. So 1 to 5 patches fall into paucibacillary category, and more than 5 patches fall into multibacillary category. So why we are categorizing them, which means the disease is more, or the viral or the bacterial load is more in people with more than 5 patches, and the bacterial load is less in people with less than 5 patches, 5 or less. So the duration of treatment also differs. Number of drugs also differs between paucibacillary and multibacillary. So duration of treatment is only 6 months for paucibacillary and 12 months for multibacillary. Look for damage to nerves. Definitely the trochlear nerves, then great auricular nerves, ulnar nerve of both the sides, and then common popliteal nerve should be tested, and it should be looked for thickening of the nerves. So these are the ways to diagnose leprosy. So then signs of leprosy. Pale or slightly reddish patch. Leprosy can occur in any pattern, like it can be macule, it can be papule, it can be nodule, it can be a patch. So it can occur in a varied way. So that is what, from tuberculoid to lepromatous, we have in between, intermediate, borderline. If you clearly define it in terms of dermatologist diagnosis. But for easier case detection, for easier treatment categorization, we count the number of patches and we categorize into paucibacillary and multibacillary. And definite loss of sensation in the patch, either the crude touch or the fine touch, or loss of function over that area, sweat over that area. So that determines there is significant loss of function over that area. Then signs of damage to nerves. So loss of sensation over the hands and feet. Weakness of the muscle. You can see hollowing of the interosseous spaces, or the lumbricals will go for atrophy, or interossea will go for atrophy because of the ulnar nerve weakness. And then visible deformity of hands, feet, and face. So what are the deformity you can expect in hands? Are claw hand, either a partial claw hand or a total claw hand. Partial claw hand will involve only the 5th and the 4th digit, whereas the total claw, little and the ring finger. Whereas the total claw will involve all the fingers with hyperextended the metacarpophalangeal joints, and hollowing of the loss of hypothenar and thenar eminences. So that's how the deformity will look like in hand. If you go to feet, foot drop. Actually, we'll have to maintain the angle of the ankle. So the dorsiflexion and the plantar flexion. The person goes for common popliteal nerve involvement. So that nerve is affected. Hence, the person flexus, that is dorsiflexion, is lost, and the person goes for foot drop. That is the deformity we can expect. And in face, loss of lateral third of the eyebrows, and the corneal sensation would be lost. Cornea can go for softening, that is keratomalacia, and sensation of the conjunctiva may be lost, going for dry eyes. And even the muscle can get weakened, and lag of thymus can be present with the involvement of 4th nerve. So these are the cardinal signs of leprosy. What is not leprosy? So I was telling you, there are many differential diagnoses for hypopigmented patch due to leprosy. So this leprosy patch is an annular patch of mainly copper color patch. The patch color would be of copric nature. Here, the other reasons which I documented was nevus. Even nevus can, white nevus can present as hypopigmented patch. And even pityriasis alba, then polymorphic light eruptions due to sun. And then vitiligo, post-inflammatory scar, steroid application can leave the skin hypopigmented. So how do you differentiate? You check the sensation, sensation is intact. And if it is present from birth, can be nevus. If it itches, it can be fungal infection. If it's white, black, dark red, or silver colored, it can be psoriasis. Scaling, again psoriasis. Appear and disappear periodically, it is not going to, it's not likely to be leprosy. And spreading quickly, I already told you, this is a disease of low pathogenicity. So even quick spread doesn't look like leprosy. Then what is not leprosy? So you look for signs of damage to hands, feet, and face. If there are other reasons like injury, accidents, burns, and birth defects can lead the person to go for anesthesia of the hands, affected part. And it can be due to arthritis. It can be due to other conditions causing paralysis. So this already I stated. So this is the way we'll have to examine the patient. Examine in a well-lit room. Examine the whole body, head to toe, front and back. Ask since when the patch was noticed. Ask what are the treatments that have been tried. And test for the sensation. Look for any visible deformities of the hand, feet, and eyes. Take a pointed soft object. It can be a cotton vest. Lightly touch alternately the patch and the normal skin, the surrounding normal skin or the corresponding area of the counterpart. That is the opposite side. Ask the person to point where they were touched. Ask them to close their eyes and repeat the procedure. So if it is lost, we'll have to declare loss of sensation. So after doing all these things, we are going to diagnose leprosy. Then after diagnosing it as leprosy patch, we are going to classify whether they belong to paucibacillary or multibacillary. So if the number of patches are between 1 to 5, which includes fifth patch, which is paucibacillary, the number of patches are more than 5, 6, 7, 8, and more than that, it is said to be multibacillary. So next, diagnosis over, classification done. We'll have to inform the patient about the disease, explain the multi-drug therapy blister pack. So the number of drugs we are going to give them, how to stick on to the treatment, why compliance is very important, and the possible side effects of the drugs as well as the disease. So the all parallel effects of the disease after starting the treatment. All these things should be explained to the patient. So multi-drug therapy is only the treatment with the drugs. Accompanied multi-drug therapy means you're giving complete information about the disease, about the drugs, about the compliance and recovery. Everything, all doubts about the disease and the treatment are cleared by giving the good, complete information. Explain the possible side effects. Ask the patient when it is convenient for him to come back to the health center. Give enough blister packs so that the treatment does not get cut in the middle. And fill out the patient treatment card properly. The documentation is also very important, right? So the treatment regimens goes like this. So once the diagnosis is made, classification is made, we have made whether they belong to paucibacillary or multibacillary, then treatment is very simple. We are going to give 6 months treatment for paucibacillary and 12 months treatment for multibacillary. So one blister pack, it's like a pill. Contraceptive pill has a complete pills for the whole month, 28 days. So like that, 6 blister packs for 6 months will be given to the patient. So the patient will consume the first day dose in front of the health worker, and his pack will be handed over to the patient and return with the empty blister pack for the next month. And definitely one more person will be given responsibility either inside the home or in the nearby area, and make sure that the person is consuming the treatment in a regular way. So this is called accompanied multi-drug therapy. So you're accompanying someone to help the patient to complete the treatment. So that is called accompanied drug therapy. So in this blister pack, what will be there? 1 dose of rifampicin, that is 300 in 2 as 2 capsules. Then 100 milligrams of dapsone, that is 30 tablets will be there. When the person comes on the first day, 2 doses of rifampicin and 1 dose of dapsone will be taken by the patient and under the direct supervision of the health worker. The rest of the pack is handed over to the patient, and he's advised to take at the same timing every day. And this should be continuously monitored by a person in the family or in the nearby area, and make sure that the treatment is being taken by the patient every day. So the next category is multibacillary, that is patient with more than 5 lesions. So one more drug is also included. First thing, only rifampicin and dapsone. So everyday patient is going to take dapsone. Every month, once in a month, the patient is going to take rifampicin. But here in multibacillary, same rifampicin 600 milligram once a month under direct supervision, and clofazimine 300 milligram once a month, and every day 50 milligram of clofazimine and 100 milligram of dapsone the patient is going to consume at home. So this is how the treatment goes in paucibacillary and multibacillary. So this is a strip. So you can see the green strip is paucibacillary. The pink one is multibacillary. So in the green strip, you have two elongated tablets. So that is rifampicin, 300 milligram plus 300 milligram, and one white circular tablet, that is dapsone, 100 milligram. So the first thing, which is in a segregated way at the top of the strip, is for the patient to be taken under the direct supervision inside the hospital, direct supervision of the health worker. The rest white tablets are the dapsone, which have to be taken by the patient at home for a period of 1 month. So after completing it, next day morning, patient should bring the empty blister pack and show that he had consumed and get the treatment for the next month. And during the new strip, the first thing, that is 600 milligram of rifampicin and 100 milligram of dapsone will be taken again by the patient under the direct supervision of the health worker in the center itself. So this is how every month goes for a period of 6 months. So this is paucibacillary treatment. Multibacillary, there are 3 drugs. So first one is rifampicin 600 milligram once in a month, clofazimine 300 milligram once in a month, and dapsone, the first dose. All these 3 are taken under direct supervision of the health worker by the patient. The rest of the days he is supposed to consume 2 tablets. One is 50 milligram of clofazimine and next is 100 milligram of dapsone. So similarly, for 12 months, 12 blister packs. So at a time, 1 blister pack will be given for a patient for a month. So if he gives a proper reason that the transport is not available or some other reason he's going away from his place, so he can be handed over the next strip also. That is called flexible multi-drug therapy. So this is the therapy for child. We already know, no? Leprosy doesn't leave children or infant and all. There is no age bar. So depending on their weight, this treatment strips are fixed. So mostly it is half of the dose of the adult dose for a patient between 10 to 14 years. So what are the informations to be shared to the patient about the disease? So agent, where it affects skin and nerves, and how is the progression, slow progression. What about the diagnosis and cure? 100% cure rate, and they can lead a normal life. They need not change their lifestyle, and it is not going to leave any disability if the diagnosis is made early and treatment is given appropriately. MDT will cure the patient completely, and it is given free of cost by the government, available in all the health centers, and it should be taken as advised. This is very important. And information about the drugs also should be given to the patient, because this dapsone can create peripheral neuritis because it is sulfonamide that can create peripheral neuritis. And patient can have neurological manifestations mimicking peripheral neuropathy. Then followed by clofazimine. Clofazimine can cause hyperpigmentation of the skin all over the body. So even photosensitivity will be increased. So clofazimine, that is a known side effect. So that should be advised, informed to the patient, and reassured that they should not withdraw clofazimine because disability is more disabling than discoloration. Then the one more side effect of rifampicin is urine discoloration, orange discoloration of urine. So patient should not think that he is passing blood through you in the urine. And again, fever, pain in the nerves, muscle weakness, joint pains. So even that can occur because of dapsone. So these are the things which should be informed to the patient about the drugs. So accompanied multi-drug therapy. Multi-drug therapy is using more than one drug for a disease. What is it? Accompanied multi-drug therapy is that these are the components. A full course of MDT at the outset. So if you diagnose a patient, a complete 6-month course will be given to the center, but patient will be given a drug for 1 month. So at the time of diagnosis itself, his treatment, complete treatment course, multi-drug therapy will be handed over to the health center. And he is supposed to receive the information about the disease, treatment, about the drugs, and when to come for follow-up, everything. And this is also another thing, that is someone who is close or important to the patient assumes the responsibility of ensuring that the patient completes a full course of treatment, maybe a family member or a neighbor. Then how we are going to manage the complications. This is a typical total claw hand. See, the hypothenar eminences are lost, and hyperextension of the metacarpophalangeal joint, and clawing of the hands. So the patient can go for leprae reactions, side effects, and leprosy after treatment. When the treatment is started late, disability will evolve definitely. And there are expected side effects which we'll have to take into account. And there are reactions which can occur in the patient while receiving treatment. And what to do? Patient should be reassured about that. The patient should seek the healthcare facility if they have leprosy reactions, if they have side effects of the drugs, if they develop disabilities in the due course of time. So leprae reactions, you have lepra 1 and lepra 2 reaction. So the treatment is that definitely multi-drug therapy should be continued regularly. Patient might think that the therapy is not working for the disease and it is creating some disaster inside the patient. No, it is an expected reaction in the patient, and patient should be given aspirin or paracetamol for the reactions. And then definitely multi-drug therapy should be continued regularly. And there is another reaction called erythema nodosum leprosum, or it can involve neuritis also. In such condition, patient should be started with a course of corticosteroids, mainly prednisolone. So this is the dosage of prednisolone with which we start, that is 40 milligram every day. 5 milligram tablet is available from starting from higher dose, optimum dose till lowest dose. So as we all know, corticosteroid is a double-edged weapon. We'll have to start properly and we'll have to taper it properly. So start with 40 milligrams, and every fortnight 10 milligrams is reduced, and coming to the end of 5 milligrams. So this is a complete 12 weeks therapy. For every 2 weeks, we are reducing the drug gradually and we are tapering and stopping the drug. So we all know the expected side effects of rifampicin: red colored urine, hyperpigmentation of the skin because of clofazimine. And it can even cause severe itching of the skin due to TAPSON, Steven-Johnson syndrome. In that case, stop all the medications and patient should seek healthcare facility. So when this disability can occur, when the disease is diagnosed at the late and when the disease is already advanced and the lepra reaction involving nerves, all these things, the disability patient is going to go with the disability. So how to take care, where can we expect the disability? Hands, feet, and eyes. So how to take care of the feet, how to take care of the hands, and how to take care of the eyes. So if it's an ulcer, we'll have to maintain hygiene, clean with soap, water, antiseptic dressing, and the exercises so that the paralysis doesn't progress. How to take care of the eyes when the person presents with redness, pain, aspirin, paracetamol, atropine, steroid ointment, and we'll have to cover the eye with eye pad in order to prevent the drying of the cornea. So this can go for corneal ulceration and permanent eye loss, that is vision loss. So when the treatment is completed, after following the treatment properly, so what are the things should be done to the patient? So we'll have to thank him for complying with the treatment. We'll have to thank the friends and family members for successfully completing the treatment. We'll have to reassure that MDT completely cures leprosy. So he is a living example and he can be a guide for another person who is affected with leprosy. Any residual lesions will definitely fade away slowly. That is the leftover of the disease. And we'll have to show them how to protect anesthetic areas or disabilities, definitely by protective footwears or preventing from the injuries. Because as the sensation is lost, even they cannot feel the fire burn or the hot tea they cannot feel and they get self-harm. So these things should be educated to the patient. Encourage them to come back in case of any problem. And we'll have to, once the treatment is completed, we'll have to remove the patient's name from the treatment register. So that's all about leprosy. And there are much more to learn about this. I've given a spark. It is your interest. You will evolve about the disease and read much more about this in depth. Thank you so much for patient listening. Thank you all.